Good evening, everyone, and thank you all for joining us here this evening. Just before I start, I just want to mention that we will be sending out a follow-up email with this recording and all the links and resources we refer to. So no need to take notes if your preference is just to sit back and listen. I'd also like to mention my colleague Kira, who has prepared all the slides for today and will be assisting and navigating in the background this evening. And I just wanted to mention Kira in case I forget to mention her at the end. So my name is Caroline Hamilton, clinical audiologist with Neuromod Devices. And I've been working with Neuromod for about 10 years now. Prior to working with Neuromod, I worked in the private practice in the Hermitage Clinic. And as a clinician, I was seeing a lot of tinnitus patients. I was getting quite frustrated, as were a lot of my colleagues, with the lack of effective treatments I had available for my tinnitus patients. CBT and hearing aids were the only options really available to me at that time. And whilst they were certainly effective for a lot of patients, we were still struggling. And there was a lot of patients who just were not finding or getting relief from either CBT or hearing aids. So I was fortunate to be given an opportunity to work with Neuromod Devices. And along with Dr. Ross O'Neill, CEO of Neuromod, Mr. Brendan Conlon, ENT consultant, and a team of scientists, engineers, audiologists, and researchers, we began working together and developing clinical prototypes and running clinical trials. So just to give you some background information on Neuromod. Neuromod Devices is a medical device company and was founded by Dr. Ross O'Neill in 2010. So Dr. O'Neill at the time working as part of a research group in Maynooth University, looking at possible neuromodulation interventions for illusory conditions, which included conditions such as tinnitus and phantom pain. These conditions are where the nervous system creates an illusory perception. So in other words, it's a perception that's actually not real. This tends to happen due to loss of sensory input, otherwise known as sensory deprivation. So in the case of tinnitus, for example, when individuals suffer a hearing loss, they perceive a sound, or in some cases, a combination of sounds that aren't really there. So Dr. O'Neill and his team decided to focus their research predominantly on tinnitus due to its unmet clinical need. And as a research team, we realized very, very quickly the significance of this unmet clinical need, especially when we started recruiting for clinical trials, as we were literally overwhelmed with the level of response from individuals signing up for the studies. In fact, we had over 7,000 patients signed up for each of our most recent clinical trials. So in terms of its prevalence, it's been well documented and well reported that 13 to 15% of the population have tinnitus. And that actually equates to 1 in 7, 1 in 8 patients, which is really hard to believe. But it is such a common healthcare condition, not just in Ireland, but globally. And patients, as well as clinicians, are desperate for effective treatment outcomes. Tinnitus has also been recognized as one of several side effects of COVID, of long COVID. The BTA, the British Tinnitus Association, have recently published a very interesting study aimed at those with pre-existing tinnitus. It was reported that COVID exacerbated tinnitus in approximately 40% of patients. And it was also reported that in 32% of sufferers, that tinnitus was made worse due to the impact of lockdown and lifestyle changes due to the pandemic. And interestingly, it seemed to be more women and younger adults who fell into that 30% of sufferers. And these lifestyle changes due to the pandemic that ended up triggering tinnitus is completely understandable, as stress tends to be a major trigger. The BTA also reported out of 121 adults admitted to hospital as a result of COVID, 16 patients at 13.2% reported their hearing was worse, and 7% actually reported developing tinnitus during this time. I suppose this really adds to the growing body of evidence that coronavirus or COVID has long-term impacts on health as well as on hearing. And we have seen this ourselves firsthand in our Centre of Excellence at the Neuromod Clinic in the Hermitage. So how does Lenire bimodal neuromodulation soothe tinnitus? So Lenire is all about altering individuals' perception and attention to tinnitus. In other words, how individuals perceive and how they attend to this illusory condition. So the concept of neuromodulation came from putting electrodes into the nervous system, so into the brain and into the spinal cord, and providing electrical stimulation in order to alter or modulate the ongoing activity in the nervous system, and at the same time driving or inducing this therapeutic benefit, or in some cases inhibiting pathological activity. Bimodal stimulation takes it somewhat a step further. This is simply a combination of two forms of stimulation, and that is usually in a synchronized or in a paired or coordinated manner in order to deliver long-lasting changes into the nervous system. And this is all achieved by driving a process called neuroplasticity. And this is the brain's ability to wire and rewire based on sensory stimulation. As I'm sure most of you are aware, this is not a recent breakthrough. It's been around for probably well over a century at this stage, and some may be aware of Dr. Pavlov's theory, Pavlovian dog, which in essence is all about paired stimulation. It's based on bringing food to the dog, and the dog salivates. And if you ring a bell when you bring food to the dog correlates this sound with the bell. Correlates the sound off the bell with the food. So even if you don't present the food, the dog still salivates when it hears a bell. So in other words, this is the paired stimulation. And some 50 years later, this was followed by Dr. Hebb's theory, heavy implicitity, who discovered that in our brains, there are cells that have the ability to code and to change the way they behave following this paired stimulation. So then if we take this again another step further to the auditory system, some years later, researchers discovered that if you present a sound at a certain frequency and stimulate the body at the same time, you can actually make the brain more sensitive to that sound, because that sound has been reinforced by this paired stimulation. So if I just go back to what I mentioned earlier, the standard of care now and up until now and currently is hearing aids and cognitive behavioral therapy, and in some cases a combination of both. Neuromod suspect that the main fundamental challenge that these technologies were facing was essentially a stimulation problem, because for a lot of patients, they just didn't seem to be effective. Neuromods believe that you actually couldn't stimulate those nerves sufficiently and effectively due to hair cell and auditory nerve damage. So the team at Neuromod started looking at other ways that they could stimulate the auditory system. And that's when they started looking at tongue stimulation and expanded the concept to bimodal stimulation. Clinical prototypes were developed based on this bimodal approach, and Neuromod started designing and running clinical trials. Following a number of trials, from our very basic pilot proof of concept trial to one of the largest clinical trials in tinnitus, our product, mute button, evolved, followed by Lenire. Lenire is a CE marked device which has been cleared for sale in the EU. Currently available at our Centre of Excellence here at the Hermitage Clinic in Dublin. It's also available in Germany and in Belgium, and we are rolling it out as we speak across Europe. Neuromod are also in the process of seeking FDA approval for the US and hopefully Canada thereafter. Lenire is a non-invasive portable device which patients can use in the comfort of their own home. As you can see from your slide, it consists of 3 components. It has a controller, which is very similar to a mobile phone, and the patient uses this to control both the audio and the tongue stimulation levels. It's got a set of Bluetooth-enabled headphones and a tongue tip, otherwise known as an intraoral device, which plugs into the top of the controller. The tongue tip has a very flat, kind of lollipop-shaped paddle that sits on the tip of the tongue. And as you can maybe make out in the picture, I know it's quite small, it has an array of electrodes, 32 in total. It's ergonomically designed to sit on the tip of the tongue and just behind the front teeth. And individuals tend to equate this sensation, this relaxing sensation, to a fizzy drink sensation or just a very slight tingling on the tongue. The device is configured very similar to a hearing aid. In fact, the software used for configuring the device is extremely similar and has been designed like hearing aid software. So clinicians input patients' hearing thresholds, and we will come to this shortly, as the device is configured to patients' hearing profile. Clinicians also have access to additional features so that it's tailored specifically to their patient's tinnitus. So in other words, you can manipulate or change background noise, the volume control, and certain features like these. The headphones are paired with the controller, as I mentioned, via Bluetooth. And we normally do this pairing prior to the patient coming into the clinic. The tongue tip, we plug into the controller. It has 12 stimulation settings, and this is calibrated to the patient's comfort level, which normally takes about 3 to 5 minutes. Finally, the clinician selects a recommended program based on our fitting protocol and configures the device prior to the patient starting the treatment. And this configuration takes approximately 12 to 15 minutes. We always recommend, and we do this currently in Neuromod Medical, that patients do a supervision visit for about 15 minutes just under the care and guidance of their clinician so that they are comfortable prior to taking the treatment home. So what does Lenire do? Lenire has been proven to soothe tinnitus and to reduce the symptoms of tinnitus. During the treatment, the patients hear sounds through the headphones, and these sounds are simultaneously mapped onto the tongue in the form of bimodal or paired stimulation. Lenire is not targeting one specific frequency, but rather the full bandwidth of hearing. So in effect, you could say that we are overstimulating the auditory system. This diverse activity in the brain not only interferes with the ongoing activity caused by tinnitus, but also makes the brain attend to this new stimuli that is being presented. This results in individuals becoming less aware and less bothered by their tinnitus. Lenire is prescribed for patients who have chronic subjective tinnitus greater than 3 months and who are over 18 years of age. Patients will attend for an initial assessment, and this may entail, well, it should entail a full audiological and tinnitus evaluation, and also a range of objective and subjective measures from a PTA, some speech and noise, uncomfortable loudness levels, tinnitus matching, and you may also incorporate some tinnitus related questionnaires like the THI, the TFI, tinnitus questionnaire. We then go through a list of Lenire's contraindications with the patients and also determine if their hearing profile is within the Lenire fitting range. And I will just discuss both of these shortly. So once the patient is deemed eligible for Lenire, we normally advise fitting the patient within 2 to 4 weeks later, just to give them time to go home and read some of the information prior to starting the treatment. Following their fit appointment, we recommend 2 follow-up or 2 review appointments at 6 and 12 weeks or thereabouts. Patients are recommended to use the treatment for 60 minutes per day. They can do this in 1 hour session, or they can split it up into 2 30-minute sessions. And the majority of people tend to split it up into 2 30-minute sessions. And I suppose they can incorporate that into their daily life much easier. And also they tend to use it maybe first thing in the morning and last thing in the evening. And that's when most people would report their tinnitus to be at its worst. I suppose upon waking in the morning, and then when they go home, maybe after work when things are quite quiet before they go to bed. We also recommend using the treatment for a minimum of 10 weeks, and that's based on evidence from our previous clinical studies. In terms of how long it takes for patients to start perceiving benefit, it's worth mentioning in one of our most recent publications from our 10-day 1 trial, you will see that the majority of patients started to perceive an improvement within the first 6 weeks. However, for some, it may take longer. So normally after the 2 follow-up review appointments at 6 and 12 weeks, patients will choose to continue using the device as a treatment daily, morning and evening, as they find it quite enjoyable and quite relaxing. Others will use it intermittently, a couple of times a week or a couple of times a month, just really depending on the natural variation of their tinnitus. And some will choose to use it as a maintenance treatment. They will get their tinnitus to a level that the symptoms of tinnitus to a level that they are more than happy with. However, they like to just do a top-up treatment every couple of weeks or every couple of months. It's also important to mention that the tongue tip actually has 180 hours of use. So normally when they have about 10 hours left of the tongue tip, an indicator will come on the controller to alert the patient so that they can go and order their tongue tip from their clinician. And this will also avoid them having to break a treatment or cease treatment, so they can order their tongue tip before the hours run out. So this is the suggested Lenire fitting protocol that Neuromod recommends. We recommend clinicians follow this as it is in line with our clinical trial protocol and outcomes. I won't go into any specific detail on the fitting protocol. We do have a team at Neuromod who will provide specific in-depth training for healthcare professionals who are interested in prescribing Lenire at their clinic. But basically, we do recommend a program or parameter stimulation, as we refer to it, to start with. And we further recommend changing the parameter stimulation at various follow-up visits. Once the patient is happy to continue using the device at home, we would normally recommend, as we do for most patients, a follow-up visit in a year, just again, so we can carry out a review, audiological and tinnitus consultation, and recalibrate or reconfigure the device if necessary. However, as with hearing aids, you may have patients who are slightly more impacted by their tinnitus, have more secondary or underlying conditions, and you may need to see them more regularly if their tinnitus is more problematic. So this leads us on to our 10-day-1 study. And just to briefly mention, all our trials and protocol papers and recent publications are available on our website, lenire.com. We recently completed our 10-day-2 trial, which is due to be published hopefully shortly. In fact, it was just submitted this week for peer review. And this was a follow-up to our 10-day-1 study. The 10-day-1 study was a double-blinded randomized trial. It was a pretty large trial which ran over 2 years, from 2016 to 2018. Again, as I mentioned earlier, we had 7,000 participants who applied for the study online, and 326 participants were deemed eligible and subsequently enrolled in the study. This trial was carried out across 2 sites here in Ireland, St. James's Hospital, under PI Mr. Brendan Conlon, and in Germany, in Regensburg University Hospital, under PI Professor Berthold Langer. The average age of the participants was 48, and the average tinnitus duration was 2.6 years. It was a 3-arm study where we looked at different parameter optimization settings as well as patient subtypes. So this leads us on to our inclusion criteria. We included those patients aged 18 to 70 years of age with chronic subjective tinnitus, who had tinnitus for over 3 months and less than 5 years, and had a baseline THI, Tinnitus Handicap Inventory score of 28 to 76. In terms of the exclusion criteria, we excluded those who reported objective tinnitus. And again, our main reason for that was because patients with objective tinnitus, it often tends to be vascular related and warrants further investigation. So we tend to refer on. We also excluded fluctuating tinnitus, as in the majority of cases, fluctuating tinnitus may indicate middle ear pathology, conductive hearing loss, Meniere's disease, and again, just warrants further investigation. And it probably is one of the more difficult types of tinnitus to look at in a clinical trial setting because of its natural fluctuation. We exclude the list of contraindications, which we will speak about in a moment, and also certain neurological medications that we felt may possibly interfere with the Lenire treatment, as we were ultimately trying to drive neural change. Patients were recommended to use the treatment for 60 minutes per day. However, the minimum compliance criteria for 10-day-1 was set to 30 minutes per day over 6 days per week. And that equates to 36 hours in total over the 12 weeks. The tinnitus severity was evaluated via the THI, Tinnitus Handicap Inventory, at the first appointment, at 6 weeks, and at 12 weeks during the treatment phase. The devices were subsequently returned at week 12. However, we continued to follow up with patients after they returned the device. and monitored their tinnitus severity at 6 weeks, 6 months, and 12 months, respectively. In terms of the overall results, there was a significant benefit improvement across all of the 3 arms from when they started to when they finished at 12 weeks. And this was something we did pre-specify. 86.2% of compliant patients showed some form of improvement in outcome measures at this 12 weeks mark. 80.1% reported a sustained improvement right out to 12 months. This, in fact, was something quite exciting. We didn't actually pre-specify, but something we continue to follow up now in our most recent TENT-A2 study. And I mean, this sustained improvement, which occurred from 12 weeks to 12 months when they weren't using the device, would suggest that there is some long-term permanent changes happening. As I said, these improvements were based on our primary outcome measures. We used both the THI and the TFI, the Tinnitus Functional Index, and these 2 validated questionnaires are highly correlated, and they measure the psychological and functional impact of tinnitus, respectively. And they're very much representative of how a patient manages their tinnitus on a day-to-day. The average drop in the THI score was actually 14 points, and most research would suggest that a drop or an improvement of 7 points is clinically meaningful. And in other words, patients will notice this drop. So anything from 7 points and above, patients will notice it and notice the improvement. And this is cited in a number of patient papers. We actually showed double that at 12 weeks, as I said, a 14-point drop, which is quite impressive. So in terms of Lenire fitting range, the device is configured to the patient's hearing profile, and the hearing profile should fall within the white area of the audiogram. So in other words, above 40 dB at the low to mid frequencies and above 80 dB at the mid to high frequencies. Also worthwhile mentioning, as it's a very common question, that Lenire can be fitted for unilateral and bilateral losses. So Lenire is currently contraindicated for active implantable devices. We don't foresee or don't expect there to be any reaction between the 2 treatments or the 2 devices, as Lenire is such a low-risk device, non-invasive. But at the same time, we have to be cautious and just err on caution. Similar for pregnancy, we're always cautious around patients who are pregnant. In terms of lesions and sores on the tongue and in the mouth, we just generally don't recommend that patients use the treatment, again, because of the intraoral device, as it may exacerbate these symptoms. And again, if a patient is using the treatment and develops a cold sore or a mouth ulcer, we would normally just tell them to take a break and resume once they clear. And just from a safety perspective, it's not recommended for those who present with epilepsy or conditions that may result in loss of consciousness. And really, that's more from a choking hazard, really, just to be on the safe side. So in terms of the different options that you and your patients can avail of, you can refer your patients to one of our partner clinics listed on the Lenire website, lenire.com, or you can apply to become a clinical partner and provide Lenire. So we currently have established partner clinics across Europe and will be establishing partner clinics in Ireland over the next number of months. and we've had quite a bit of interest from clinicians. However, the easiest way to refer your patient at this moment is through Neuromod Medical, our Centre of Excellence in the Hermitage. You can refer your patient directly by submitting a referral form on their behalf, and you can do this via neuromodmedical.com/refer, or patients can refer themselves directly by completing their own booking form online. So this is a Neuromod Medical website. Patients can access the booking from here. As you can see, they can just click on the little green area, or you can click on refer your patient. Once we receive their information, customer service will contact your patient and offer them an online or an in-clinic appointment. And for those of you that may not be aware, Neuromod just launched their teleaudiology service in February of this year. And obviously, due to the pandemic over the last year, we've been inundated with patients who have signed up for their treatment online as opposed to in clinic. Also, just to mention, we don't just assess patients for Lenire. We will provide consultations for patients and will happily advise them if we feel there is an alternative or a better option available to them. And obviously we'll refer back to you, or we can recommend and refer them directly. And just to finally mention, as I said, we have been inundated with inquiries about becoming a clinical partner and prescribing Lenire. So if you are interested, you can go onto the Lenire website and click on the healthcare professional link, and someone from our customer or commercial team will be in touch and will follow up with you.
So now, if anyone does want to ask any questions for Caroline, if you can, sorry, this is Kira here speaking, by the way, the phantom voice. So you can type into the Q&A section up the top of the webinar. And we have a question for you to get started, Caroline. So this question is coming in from Raheen. Thank you for the presentation, very informative, well done. Any contraindication with medications? Can any medication reduce effectiveness of the treatment or increase it?
So thank you for that question. Currently, we have no contraindications to medications. I've provided the list of contraindications, and medications aren't included. However, always on the air of caution, if we have patients who have underlying conditions, which we see a lot with tinnitus patients. So if they are on medication or have just started medication recently, we normally wouldn't recommend Lenire until they have been on that medication for at least 3 months. And we will always go back to their primary physician or their consultant just to make sure that they're happy with the patient starting a new treatment.
Perfect, thank you. The next question we have come in is any timeline for FDA approval for the United States?
So we are just currently in the process of submitting to FDA. We work with them very closely, and they have been providing guidance to us as well. We would be very hopeful, obviously the year that's in it, we would be very hopeful to have FDA approval by the end of this year.
Perfect. Next question coming up. Can other professionals such as neurologists and chiropractors be approved to use the device?
Absolutely. I mean, anybody, I mean, what we're seeing at the moment is, I suppose, tinnitus patients fell within the audiology scope of practice and ENT. However, now we're seeing a lot more clinicians, speech therapists, neurologists, seeing patients, psychologists. So certainly if you're interested as a healthcare provider, as I said, you can leave your details and on our lenire.com webpage, and we will certainly be in touch.
Next question from Dr. David Thomas. Thank you for the presentation. Can you give me an indication of cost for the device and treatment? Thanks.
So the cost of the device, and Kira, we have a slide here if you want to just bring it up. So, so at Neuromod Medical, the initial assessment costs €200. Online, it is €100, and the reason we waive €100 off that fee is online we can virtually do everything apart from their audiological PTA assessment. So we normally ask patients to go and get a test done and just provide us with a copy. So as I said, the consultation fee, depending on which route the patient chooses, is €100 for online, €200 for in clinic. And the next slide, Kira, will just show the, so in terms of the options available to the patient can choose to pay up front, which is $2,400, or they can choose a second option to pay in installments. And the second option is probably our most popular option for obvious reasons. The patients can pay in 3 installments at their fit and their 2 follow-up visits. However, they have the option to return after each of those if they decide after the first installment they don't want to continue any further. They'll have 6 weeks done, or they can do longer and see how they get on.
Brilliant. Very prepared with our slides. Next question in there is, do you recommend any consultation during the treatment, or is it purely use of instrument?
Can you just repeat, do I recommend?
Any consultation during the treatment.
Oh, during the treatment. So I'm hoping I'm answering this correctly, but during the treatment phase, we recommend that the patient comes back for 2 follow-up appointments. And based on our fitting protocol that I showed earlier, and as I said, prescribing clinicians will receive a full in-depth training on the fitting protocol as well as Lenire. We do recommend that patients come back at 6 weeks in or around and at 12 weeks, as we do recommend that they start on a specific program, which, as I said, we refer to as a parameter stimulation program. And at the follow-up 6 weeks and 12 weeks, we recommend that you change the programs at both of these appointments. So yes, at least 2 follow-up appointments. But again, I think it's worthwhile also, as I mentioned earlier, depending on the severity of the tinnitus and how problematic and underlying conditions, you may need to see your patients more often if they just need some guidance and some help.
Perfect. One more question come in there. Will Lenire work for patients who have severe tinnitus and no hearing loss?
Again, that's quite a common question. So I will answer yes to both of those. So just deal with both of them separately. So I think one of the positive aspects of Lenire is the fact that we can fit it to patients with normal hearing. Prior to Lenire, as I said, we had CBT and hearing aids, and whilst they were very beneficial to a lot of patients, for those with normal hearing, we really struggled, as we obviously couldn't fit hearing aids, and most patients didn't want to go down the kind of sound enrichment route or masker route. So Lenire can be fitted for normal hearing, which is great. In terms of the severity of tinnitus, yes, no problem. But I suppose in terms of how do we quantify severe tinnitus, most patients will quantify that themselves. It's self-reported, but it's what I'd say is send your patients into us. We will carry out the full audiological and tinnitus consultation, as well as the THI and a number of other questionnaires, and determine if your patient is suitable for Lenire. I mean, in some cases, we have patients who may fall into the severe catastrophic THI grade on the tinnitus handicap inventory. They benefit really, really well from Lenire. And in some cases, we have patients that maybe fall into the moderate category, but have a lot more underlying and red flags, and we may need to maybe send them down the psychology route for a couple of weeks or a couple of months before then we bring them back to try them with Lenire. But I think the answer to that question is yes, in terms of severity and in terms of normal hearing.
That leads quite nicely into our next question, actually. If patients are not suitable for Lenire, what is the alternative? What would you recommend?
So again, when patients come to us, we will determine the severity and the impact tinnitus has on patients. And in a lot of cases with tinnitus, you sometimes have to park the tinnitus and look at the underlying and secondary conditions that a patient presents with. And if we have a patient who really struggles with their hearing, and even though they may tick all the boxes for Lenire and there's no contraindications and they fit the fitting profile, we might recommend they go down the hearing aid route first, because ultimately they're going to have to go with a hearing aid, in due course. So we may recommend they go down the hearing aid route first and then come back to us in about 3 months' time once they have tried or purchased an aid. Again, some patients that come to us, they may be treatment naive, or they may have tried numerous treatments and may present to us quite psychologically distressed, quite highly impacted by their tinnitus. Maybe they're not sleeping at night. And again, that would be reason to refer them maybe down the CBT psychology route, or in some cases to a sleep therapist before we would actually start them on Lenire.
Okay, that's all great. I think that might be the end of our questions from the audience, unless anyone has anything else that they'd like to type in. That might be us, but again, as Caroline mentioned at the start, we will be sending out a copy of this recording of the webinar and a list of useful links and resources that Caroline touched on throughout the presentation.
That's great, Kira. Thanks for that.
Oh, I'm sorry, we've had a last minute question come in. So actually, maybe this might be one you might have to follow up on offline, but thanks for the very comprehensive presentation, Caroline. That came from Genevieve Butler. Who would you recommend as a sleep therapist in Ireland?
So normally we refer them back to their GP and recommend sleep therapists, just again to keep a GP in the loop is very important. There is a sleep therapist whose name has just slipped me, based here in the Hermitage Clinic. So Genevieve, I know Genevieve, so I can certainly provide Genevieve that information.
Brilliant. Okay, well, thank you very much, Caroline.
Thank you, Kira, and thank you everybody for your time this evening. And as I said, Kira will send out a link to the presentation and the recording. And if you have any questions, please feel free to get in touch.
Brilliant.
Thank you.
Take care.